Thanks for joining us. My name is Raelynn, and this is our very first podcast post for our series, Visceral CHASE. And this idea of our passions helping to bring us forward with our dreams and how we can help others. So, visceral is this will over the flesh that continues our journey to bring us to our purpose. And so I am so pleased today to introduce you to someone who has done that so eloquently with their career, and her name is Ashley. So Ashley, please give us an overview of your career and where you are now with your studies and your work.
Sure. So I completed my Bachelor of Science in Nursing at the University of Western Ontario in 2010. And then I took a position in the emergency and SCU in Thompson, Manitoba, which is pretty far north, but it gave me a lot of hands-on experience. After that, I moved to Edmonton, Alberta, and I started my master's degree in nursing. Fortunately, I got a big scholarship to do it. So I ended up with a master's of nursing, a nurse practitioner with a specialization in aging, and I graduated in 2015. Since then, I've been working in the geriatric population in supportive living and facility living in Edmonton, and recently started my PhD with the University of Alberta in the public health realm in health policy and research.
Incredible, incredible. Thank you so much for being with us today. I'm going to just jump right into some of the formal questions we have prepared for you. So, what inspired you in the first place to go into nursing?
So initially, I always knew I wanted to be in healthcare. I did excel in that area. I wanted to help people, and I was really interested in physiology, pathophysiology, just helping humans essentially. So I started by going into pre-med, actually at the University of Guelph, and I discontinued that program just because it was going to take so long to get into the field I wanted to be in. So I switched over to my Bachelor of Science in Nursing at the University of Western Ontario in 2010.
Wow, wow. And so, with that being said, was there something that initiated that switch? Is there, um, someone who would be in your position, right? Who maybe is going into pre-med? What was that kind of spark for you that had changed your mind?
Yeah, I just really wanted to have a very focused and hands-on experience, and doing pre-med for 4 years and then trying to get into med school. Then I would be starting that, but I would need that undergrad, and organic chemistry wasn't my thing.
Okay, good to know. Yeah, no, totally. I understand. And so now that you've been in the field for over 5 years, do you think, just in hindsight, did you imagine yourself where you are now? How does that connect?
Well, I've actually been in the field for about 10 years now.
Right,
As an RN, about 5, and then as an
right.
NP, 5. So,
Okay,
uh, did I imagine myself here exactly? No.
right.
I always knew that I wanted to pursue advanced education after my bachelor's degree in nursing. I always knew I wanted to be an NP. There was very few of them in Canada at the time.
Mhm.
There's thousands now, so it's an amazing accomplishment that since the 1970s we've come so far in that.
Yeah.
However, no, I didn't imagine ever ending up in Alberta. No.
Well, good for you. It is your journey, and yeah, we're miles away from where we were. So that is why I say it's truly an honor to speak with you. And yeah, pardon me, the 5 years there, 10 years of experience. So just brilliant, brilliant. Uh, for our next question. Now, we know that you've worked in pediatrics during the early part of your career, right? And now you're specializing in palliative care, end of life care. And with that being said, was that a conscious choice, or how did that come about for you?
I think I loved peds before I had kids. And then I had kids, and it got so much harder to see sick kids. So when
Right.
I graduated, I did specialize in aging through my program. So I knew that I wanted to work in a geriatric population. So it was a conscious choice. to move from the beginning of the spectrum of life all the way to the end. And I love geriatrics. I wouldn't trade it in for anything. I love providing good palliative and palliative end of life care as well. It's truly an honor to do that.
It's very rewarding, I can imagine.
Yeah.
Wow. And, you know, being a mother myself, I commend you for having that strength to be able to play so many roles. Yeah, I just had to say that. So just to lead into the work you're doing now, let's talk about that. I want you to give us an idea of, you know, your background a little bit further for everyone, and then as well just what your findings are now, and we'll go into a couple of questions about your methods of research.
Okay. So initially, I never thought I would do a PhD. After I did a master's degree, I made a promise to myself I wouldn't do the PhD. Well, I'm doing it because boots on the ground, I was noticing a lot of inequities in the end of life care we're able to provide in the community, in that we're significantly lacking, unfortunately, in that ability to keep people at home and keep people comfortable for home death and to provide support to the families in the home. So what I was finding in supportive living is if you were paying out of pocket for a private bed, there was less resources available. Families were having to pay additionally out of pocket for care in the home, which I found to be really disheartening because everybody has an end of their life and everybody's going to go through this, and they should be able to do so in the place of their choice with the people who they choose to be around them. So I could fight this from, the position that I was in, but I wouldn't get very far. So what needs to be done is a policy needs to change, funding needs to be allocated, and we need to figure out a better way to implement good palliative and palliative end of life care in the community, because the last thing you want is to be transferred to the emergency room to die.
Yeah.
So that's what I'm doing. And right now we're looking at, for a thesis topic, is integrating a new mobile health unit to respond to people in their homes, to provide education and support to families, and able to provide emergency palliative end of life care when needed to prevent hospital admission, so that we can keep people at home and comfortable in their own beds. As we know, sometimes if they're that frail, the second you transfer them, they pass away. And it's just not the right set of scenario. And people do remember how people die. Your family remembers how you die. And if you want to have a good death, that's how they'll remember you at the end. So I think it's really important that we do some research into that. And it will be likely mixed methods, both qualitative and quantitative. We have not nailed down the research question quite yet. For my thesis topic, in my master's degree, it was a quantitative analysis retrospectively looking at the incidence of oligoanalgesia in adult Colles fracture patients admitted to the emergency department. The hypothesis was that elderly patients were undermanaged for pain. In the end, what we did find was that, yes, oligoanalgesia was occurring in the ED. However, it wasn't in the degree that we thought. What was happening was that pain was either not being assessed at all and not reassessed in 100% of patients. In fact, only 47% of patients received a reassessment of pain after given something for pain. So in a way, yes, it was occurring, just not in the way that I thought it was, but that's interesting.
Wow. My goodness. This is powerful. I'm so honored. My goodness. So again, I know you were mentioning before that throughout your experience, you are going in, like you just mentioned, you're going in to have a finding in your research, and then you're kind of seeing along the way where the holes are and where things need to be fixed. Now, where we are presently with COVID-19, this pandemic, the home care has to be there. This has to be the way we're doing things. So what you're doing is leading us there. So thank you for doing what you're doing. And we could not ask for a more powerful voice and soul to be coming forward and to speak on behalf of those who cannot speak for themselves. Because my mother passed away in home, and God willing, we had that opportunity to do that. And we had a community surrounding her, and that's the way it should be. And I just can't say enough. So thank you again.
You're welcome.
I don't want to cry, but it's such a beautiful person. So, so again, at this point, I'd like to move into your PhD research a bit further. And so, again, when you're sticking with this topic here, and I know that some questions we wanted to ask you were in regards to if your findings, like if you're liking being in research more, if you like being hands-on with patients more, where do you see yourself in the future? And in regards to the policy that you're hoping to bring forth, why don't you give us more insight into that as well?
Yeah, the trajectory of my career is still up for debate. I'm still in the infancy of my PhD. So I would not imagine ever giving up at least, I'd like to keep at least part of my clinical role,
Uh,
if that's possible, because I do like providing that bedside care. But in order to affect policy change, I'm going to be likely looking at some sort of a government position as well, in who knows where exactly, but informing policy to the decision makers. And that could be at a faculty level, that could be at a government level, that could be at an administrator level. I'm not really sure yet.
yeah, absolutely.
The research
Start
will
manifesting it.
yeah, I don't know yet. It's 6 years away.
Yeah.
Um, so not too sure on that yet, but we are looking also at what inequities COVID-19 impact has had on palliative end of life care in the home as well. I know that there's been some issues providing that care in person, as well as medical assistance in dying as well in the home. There's been some issues with that as well, especially because we're limiting family contact even for people who are passing away. So it's been an interesting journey so far, and hopefully there's a vaccine and an end in sight.
Absolutely. God willing.
Yeah.
And I want to touch back on the work you're doing with your patients. I know you were doing teleconferences, right? So I'm not sure how deep you can get into that, but
Right. Well, I do go still into the homes of people if I need to. It's a proper protection. There's lots of protocols in place. But really, we're limiting our foot traffic into our sites because the population is so vulnerable right now. If you look at Ontario, like over 200 long-term care sites have been affected. We have been super successful in Edmonton about limiting that. However, we want to reduce the likelihood that that would occur. So I'm doing a lot of telehealth right now, a lot of phone calls with site staff, phone calls with family, FaceTime with my patients if they're able to, and providing a lot of telemedicine essentially over the phone and faxing orders in just to decrease the amount of people coming in and out of that site.
right. And I think this will be the final question that I have for you today. This kind of just popped in my head here, and I'm thinking, what advice would you give to someone right now who is dealing with, a loved one or caring for a loved one who's at that stage, end of life, and they're in palliative care, and there's all these different choices they have to make? What would your words of wisdom be to the community?
Well, hopefully they're already under the palliative care umbrella because there's lots of people who don't even have home care and are at that stage of life. So reach out. There are resources available. Palliative home care can be a great resource. Particularly in Edmonton, we have a great palliative team that we have palliative docs, and they come out with their palliative nurses, do an assessment. Sometimes they pull me in if I'm an NP attached to that patient
Mm,
to provide that care ongoing, because it is so involving and it's very high needs. And a lot of the times, you can't get to the clinic, you can't get a hold of your family doctor, but there are other resources that you just need to investigate. In order to make decisions, I mean, really, it's for the comfort of the patient and the family. And there's lots of great education online as well. Pallium is pretty great for some tidbits on palliative end of life care and what to expect, because it can be kind of scary and daunting for people who don't know what to expect in terms of that. But there
absolutely.
are resources, so just reach out.
Absolutely. I know it can be daunting too when you're having to explain to multiple family members. So that's also great that you mentioned, there are resources there.
And have early conversations prior to getting to that stage of your life. Talk to your family about your goals, wishes, values. What should your goals of care designation be? I know in Ontario they call it a DNR. Here we call it a GCD. But have those conversations about what you want when that time comes so that people are aware, because they don't want to be guessing. That's more stressful.
Right. Prepare for the worst, hope for the best.
Yeah, right.
Exactly. Well, that is wise. Thank you again for what you do, for your time today. And we look forward to working together with you. I know you're out in Alberta now, but I do know you're a Londoner, as I am too right now for the first time. And I really do enjoy London. So when you're a bit closer to us, it'll be great when we can meet in person if you have the time.
Absolutely.
And once things have passed over. But again, I'm wishing you and your beautiful family well.
You too.
And I'm wishing you all the best in all of your endeavors. I know your voice is going to be heard and you're a change maker.
Thank you.
Yeah, absolutely. Thank you.
Okay. Bye.
Take care.
Bye.